Hi everyone, my all videos are liked by the people and I am happy and I have been requested that I should do the video of the fibula, which is a very slender lateral bone of the leg, and functionally it takes no part in the formation of the knee joint, but it takes part in the formation of the ankle joint. And you will see this slender bone is so important because it gives attachment to many muscles, and it is fractured, that will tell in the clinical anatomy part. Though this bone is vertically placed, you will see the borders and the surfaces of the tibia tracing is very much ferocious to every student. But it is very easy in the examination. If one can trace this border and surfaces, he or she will get the good marks. You will see the fibula borders always start from below, not from above, because from the below it is written by the original grey book that always trace the border from below. You will see here the triangular area, and this triangular area, from the apex of the triangle a border begins and ascend upwards, very sharp border upwards. How far? This border goes near the neck of the fibula. This is the upper part known as the head of the fibula. This is the lower part known as the lateral malleolus, and this is the shaft of the fibula, and this is the anterior border of the fibula, which fades away near the neck. So I will show you the anterior border. Then you will rotate the bone and you will see this border. Nearer to this border there is another minute border, and this border is separated below, but when it ascends upwards, you see this border will actually there is gap between the two border, that is the anterior border and the interosseous border or the medial border. It is very much less, only 1 to 2 millimeter space exists. Next is the posterior border of the tibula. How I will trace the posterior border of the fibula? You see there is a triangular area over the medial end of the lateral malleolus. From this triangular area, this border begins and ascend up, and up to this neck of the fibula, this border is more prominent, and in the upper part it is less prominent. So this is about the border. Now about the surfaces of the fibula. You will see that I have made the different surfaces different color, and you will see between the anterior border and the posterior border, this surface is known as the lateral surface, and in this lateral surface there is attachment of, or the origin of, the peroneus longus and the peroneus brevis muscle, and the lower part there is some gap. And if you go to the lateral malleolus, you can feel behind in your body or other body the two tendons of the peroneus longus and the peroneus brevis muscle. And you will see this anterior border and the medial or interosseous border, there is a very small surface, and this is known as the medial surface or extensor surface. You see how narrow this surface is. Though this is the narrow, but here from the extensor digitorum longus, from above the extensor hallucis longus, it arises from this surface. So you will see the lower part gives attachment to the peroneus tertius. So you will see from this small surface, you will see this surface is small here. you will see, which I have marked here, the color that is of purple color. You will see this is the extensor surface or the medial surface of the fibula. Next thing, you will see that this white color area, which I have not give any color, this larger surface which is known as the posterior surface of the fibula. So this is also the posterior surface of the fibula. This is. Now in this posterior surface you will get a median ridge, and this is known as the median crest, and an artery is related to the median crest, that is known as the peroneal artery. And in this space it divides into lateral part and the medial part. You will see the lateral, that is the medial part is, and this is the medial part. This is more hollowed out. Why? Because there is the attachment of tibialis posterior muscle which makes the foot inverted. So this is known as the inversion. When the medial border of the foot raised, that is known as the inversion. So that strong muscle is attached here. And the other area you will see in this, the posterior surface. So there is, you will see there is the attachment of tibialis posterior, and on the you will see here on the lateral aspect there is the attachment of the flexure digitorum longus, flexure hallucis longus. Flexure digitorum longus arises from the tibia. So the flexure hallucis longus is more bulkier than the flexure digitorum longus, because we know our great toe that bears about double the weight in the transmission of the body weight, and when the flexure hallucis longus, it produces flexion of the great toe. So this is more powerful. That's why this is the, you will see from the posterior surface of the fibula, that is lateral to this median crest, arises the flexure hallucis longus. So this is the shaft of the fibula. Now you will see the head of the fibula. The head of the fibula, you will see there is a facet, and this facet articulates with the facet on the tibia, forming the superior tibiofibular joint. In the middle they are connected by the interosseous membrane, form the middle tibiofibular joint, and in the lower part there forms the inferior tibiofibular joint.
Bas.
Now the upper end possesses a projection, and this is known as the styloid process of the fibula, and this styloid process gives attachment to a tendon which is known as biceps femoris. It is very important because in this styloid process the lateral ligament of the knee is also attached. So you will see here in the head. Now in the lower part, you come to the lower part, the lateral part is projected downwards and forms the lateral malleolus. Its medial aspect, you will see anteriorly there is a triangular facet which articulates with the trochlea. Here this is the trochlea of the talus, producing the ankle joint. That means the it forms the tibiofibular mortise, and this mortise articulates the upper end of the talus. Now you will see behind that articular area, you will see a groove, and this groove is known as malleolar fossa. This is very important because you should place your thumb in the malleolar fossa and it will determine the side of the bone. You will place the upper end above, lower end identified by the malleolus, that is below, and you should put it in the straight way. This is the anatomical position, and this my fibula that is in my hand, that is of the right side. So you will think this is the sender bone. It does not take part in the weight transmission, does not take part in the formation of the knee joint. But why it has got so importance? Because its lower end forms the ankle joint, because its surfaces are so designed that the muscle, the most of the big muscles arises from that. You can feel this muscle behind your back of the calf, and you will see, and also in front of the leg, this muscle you can feel. So all this muscle, you think this such a narrow surfaces, how they give origin to such a muscle? So because the origin of the muscle is very thin, linear, that is like the onion peel like, so origin, but gradually it becomes bulky, and in the lower part it becomes a tender, you know. So this is the, so there is so many muscles are attached in this bone, that is the fibula. Now the clinical anatomy part is that the neck of the fibula is related to an important nerve, and the name of this nerve is known as the common peroneal nerve. This is very important. This common peroneal nerve, you can trace it about the medial border of the biceps femoris. Now this common peroneal nerve in the neck of the fibula, it divides into two. One is known as the deep peroneal nerve, another is known as the superficial peroneal nerve. So deep peroneal nerve goes to the anterior compartment of the leg, and superficial peroneal goes to the lateral compartment of the leg. And this part is subcutaneous. Somebody can actually beat you in this region by means of stick or rod. So there may be the paralysis. Now the lower part of the bone is prone to fracture. It is not fracture alone. There may be the fracture of the medial malleolus of the tibia. How it is fractured? Because of the any fracture is either due to direct violence or there is any twisting force. If your foot is twisted by dipping it into a ditch or narrow hole, then this foot is twisted and there is fracture of the lower end of the fibula. So this is the second point. Third is that sometimes there are cancer in the mouth and that affects this mandible. That means this region, you know, the mandible. So you can feel also the mandible. So when one has to remove the mandible half, so other part there is no mandible. So what will be the look of the patient? So you will see the look of the patient will be distorted, and the surgeon will do, they take the lower part of the fibula beneath the periosteum and it grafted over this region, that is the region of the mandible, and they make beautiful look, not the horror look, so that the patient mentality becomes elevated. So you see here, this is a subject where I can feel the lateral malleolus And you also see the prominence of the lateral malleolus. There is a groove, and this groove you will see I can palpate the tendon of peroneus longus, which comes from here, and deep to that there is the peroneus brevis muscle. And you will see this is the head of the fibula, and I can palpate it, and this is the neck of the fibula. In this neck of the fibula lies the common peroneal nerve, which I have told to you. So this is relation to the common peroneal nerve. And it divides into two, that is the superficial peroneal and the deep peroneal muscle. The deep peroneal supplies the muscle of this anterior compartment of the leg, and the superficial peroneal supplies this lateral compartment, that means the peroneus longus and peroneus brevis. Now you should see the lower part of the fibula is used for grafting, which I have told you, and that is in this part. This one is taken below the, that is the periosteum. Periosteum is not taken. Now you will see this lower end is prone to fracture because of the twisting injury, and you will see here the hallucis longus, which I have told you. You see this one, this tendon is very strong, that's why hallucis is more bulky, and this one, this fourth tendon, you will see not, so you will see this tendon, it is less bulky in nature. So this is how you can feel. And you see the physiotherapist, they use this point, the neck of the fibula, and also near the lateral malleolus, to give the stimulation, the current, because they either want to block the stimulus or they want to stimulate this region to actually the to the muscle, the paralyzed muscle, and also there is any urinary retention, because through the spinal nerve, you know, the sympathetic, parasympathetic all goes. So thank you everyone for watching this, and suggest me for doing more and more videos, which one should be required by you.